Hello and greetings from UB. On behalf of the Office of Alumni Engagement and the UB School of Public Health and Health Professions, we are delighted you are able to join us for today's webinar presentation. My name is Christy Fields and I'm the Director of Alumni Lifelong Engagement here at UB. I am also joined by my wonderful colleague, Joy Rona, who will assist in monitoring any questions. We are both so grateful you are able to join us today, and I hope you and your family are staying well. It is my honor to welcome today's featured presenter, Dr. R. Lorraine Collins. Dr. Collins was just recently appointed to the rank of SUNY Distinguished Professor, the highest faculty achievement in the SUNY system, and we are so fortunate to have her as the Associate Dean for Research and Professor in the Department of Community Health and Health Behavior right here in the UB School of Public Health and Health Professions. Dr. Collins is a psychologist who has conducted NIH-funded addictions research for decades. She is a national renowned expert on the health effects of cannabis, was named to a working group created by former Governor Andrew M. Cuomo in 2018 to draft legislation on how to regulate marijuana usage in New York State. Most recently, Dr. Collins led the development of the Center for Cannabis and Cannabinoid Research at UB, which is a multidisciplinary center that includes faculty members from various decanal units, all focused on addressing the paucity of research on every aspect of cannabis. Today's presentation will provide an introduction to the cannabis plant and to medical and recreational usage policies and issues in the United States. Dr. Collins will also highlight the ongoing implementation of New York State's Marijuana Regulation and Taxation Act, which was recently passed on March 30th, 2021. We will also leave some time during today's webinar for Q&A. If you have any questions during the presentation, go ahead and submit them. You have that GoToWebinar taskbar. There's a question section on your screen. Chat those to us at any time. In addition, we'll be recording today's session and we'll send you all a copy within the next 24 hours. So with that said, it's my pleasure to turn it over to our featured presenter, SUNY Distinguished Professor and Associate Dean for Research and Professor in the Department of Community Health and Health Behavior in UB School of Public Health and Health Professions, Dr. R. Lorraine Collins. Welcome, Dr. Collins.
Well, thank you, and thank you for that very gracious introduction. I am very happy to be here. One of the things that I really enjoy is talking to people about cannabis because it's such a hot topic and there's so much misinformation that whatever I can do to share, even at the most basic level, my knowledge of cannabis, I am happy to engage with the audience. So let's get started with some recent headlines. And as you can tell, it's all over the place. Vaping illnesses, medical cannabis, you know, does getting stoned help you get toned? It's just, as I said, a very hot topic, and many of the so-called facts about cannabis are myths. And so one of the things I hope to do today is to provide scientific information rather than information that reinforces the myths. So the first thing I want to do is to alert everyone to what a complicated plant we're talking about. The cannabis plant, typically you hear about 3 species, sativa, indica, ruderalis, but what's available these days usually are what's called hybrids. And so those species, based on genetic engineering, kind of are grown to specifications around certain characteristics that the grower would like to see. Within the plant, there are 500 what are called phytochemicals and over 100 cannabinoids. And those are components that we hear a lot about. But the 2 key components are THC, which is hydrocannabinol, and CBD, which is cannabidiol. There's been recently more coverage of delta-8 THC. These other cannabinoids are just, the start of a long list. But for the most part, I'll be focusing on what we know with regard to THC and CBD. This is a very simplified diagram, but what it attempts to show is that the cannabis plant has cannabinoids and non-cannabinoids. Among the cannabinoids, we have psychoactive, active, and inactive components, or at least inactive as we know now. The psychoactive cannabinoid is THC or cannabinol, and then CBD, which we've talked about before, is cannabidiol. Generally, when we think about cannabis policies, they are designed around the two components that I mentioned. One of the things that happened in the 70s is that cannabis was regulated. It was designated as a Schedule I drug by the Drug Enforcement Administration, and it's also regulated by the Food and Drug Administration. So these are two federal agencies that really tell us what we can do with cannabis. And just so you understand, the Schedule I designation is given to heroin and other illegal drugs that are said to have high potential for addiction and no medical usage. And as we will see, there are medical uses to cannabis, and so that designation is very much being questioned, although nothing has changed. Under federal law, cannabis that contains THC is illegal, but CBD products are allowed, and that really took off in the Farm Bill of 2018, where when talking about the growing of hemp, the Department of Agriculture allowed products that had very, very low levels of THC, but were mostly focused on CBD. Entrepreneurs and other advocates for cannabis kind of jumped on that, and with that came the proliferation of CBD products, which you can see everywhere, at Wegmans, at a gas station. So anyway, we've got two important dates. One is 1996, where medical cannabis started in California, and the other is 2012, when recreational cannabis started in Colorado. The thing to know about what happened in California in 1996 is that medical cannabis became available through a proposition. It was basically voted on. There was no science involved, there was no medicine involved in terms of testimonials or evidence as to the contributions that cannabis could make to promoting health, but advocates were able to get, and it was a very close vote, advocates in California were able to get a proposition on the ballots, and that's how medical cannabis started in the US. So this is a map. It's almost a year old, but it gives you a very good idea of the patchwork of policies that exist in the US. The darker colors are for states that allow adult and medical use, and New York, as you can see, is in that. New Jersey is in there, and Connecticut. And so that's kind of our area, the Northeast region of the country. A lot of the initial programs started out west, so Colorado, Oregon, Washington, California, Nevada, and so forth. You'll see that there are 3 states where to this date, there are no public cannabis access programs. But over the years, many states have adopted at least medicinal cannabis and some medicinal and recreational. And what they're providing access to are both natural and synthetic cannabis and cannabinoid products. Cannabis typically is available in smoked and non-smoked forms. Although smoked is the least effective way of delivering health benefits because it includes harmful substances that go into the lungs, it still is quite popular. CBD comes in oils and sprays and capsules. There are oral capsules and sprays for THC. And then there are a couple of products that are FDA approved that are based on natural cannabis. One of them is called Sativex, and it's been in testing for a while. It is available in Canada and Europe, and the FDA has approved it for pain in multiple sclerosis. And then Epidiolex, which is mostly CBD, 98% CBD. It's been shown to reduce seizures in 2 particular childhood epilepsies, although I am aware of research where people are trying to see if Epidiolex can help with other childhood disorders, including autism. So that's for the future. Then we have synthetic cannabis products, some of which have been around for a long time. So mostly they're licensed to treat nausea, vomiting related to chemotherapy, and anorexia and wasting related to AIDS, which is less of an issue, but for a while we were really just devastated by AIDS wasting syndrome. And so these drugs were used in those situations. They're all synthetic. They're based on THC, although the Nabilone, they're just different versions. So Nabilone is oral, Dronabinol is liquid, and so forth. I just want to make a note that there are what are called synthetic cannabinoids that are sold for recreational use. They are just often just based on chemical preparations that are sprayed on herbs. So they are synthetic, but they shouldn't be characterized as synthetic marijuana. So here are a lot of products that contain cannabis. To my left is flowers, brownies that you can eat. Towards the center, we have resins and shatter and various forms of hash. Those are products that are derived from cannabis, but highly potent. Then we have a number of products that are edible. So we have cannabis dark chocolate, cannabis coffee chocolate. Above it, we have vape products, and then the 2 FDA approved products that I mentioned, Epidiolex and Sativex. So this is just to give you a sense of all that's out there, and this doesn't even include the range of CBD products that are out there. People can use cannabis in different ways. Smoking is what most people think about. They can smoke a joint, a pipe, or a blunt, which is combining cannabis and tobacco, Hookahs are used, eating, of course, and vaporizers. This is a jewel type product, and this is actually a very kind of almost industrial way of vaping that is, as vaping goes, seen as relatively safe. So vaping products don't combust the cannabis, but they heat it. They heat the plant material. And as you can imagine, and this is 2018 data, most people are still smoking cannabis. Vape is rising in popularity. Edibles definitely are rising. Topicals, which are cannabis products that you put on your skin, not that much. And then multiple forms, including combining cannabis with other substances, such as tobacco. Smoked or vape forms of THC or CBD are absorbed rapidly, just like nicotine is absorbed rapidly. We did go through a period where there was concern about vape products. I just want to mention, because there was a lot of media attention to it, the focus was on vaping of cannabis, but actually the problem was how the vape product was prepared. It included vitamin E oil that affected the lungs, and I know that there were some deaths related to it, but again, the issue was not the cannabis, the issue was how the vape product was prepared. Eating and oral modes lead to higher concentration. The challenge there is it's more difficult to titrate because it takes a while to be metabolized through the gut. We've had situations where people have a half of a brownie and think, oh, I'm not feeling anything, I should be getting high. And then they have 2 brownies and then they're in the emergency room because they're having a psychotic episode. So when oral or eaten cannabis is involved, people really have to take the time to wait until the product is absorbed and metabolized. Another issue with cannabis is the potency of the product. The typical forms that are used, for example, flowers and leaves, the potency of some of the hybrids that are now being grown is up to 30%. I mention that because the flower that people were consuming during the Woodstock years into the 70s was very low potency. It was probably 5% or less. So now what's made available is usually in the 25% range of potency. Oil is relatively low potency, but the extracts and the shatter and some of the other products that I showed you in the picture earlier, you can get THC products that are up to 90% potent, and that should not be allowed, but it is. And the marketers make the point that the higher the potency, the better the high, but it's also that the higher the potency, the more you can get into trouble. You've got hash, which is up to 60%, and then other products can vary depending on how they're prepared. This is an example of what's happened to potency, and these data are from the FBI and products that they have gotten from criminals and other illegal enterprises. The key thing is to look at what has happened since 1995, where on average the product that the FBI was finding was around 4%. In 2018, it was around 16%. And again, these are from drug busts. What's available on retail is much higher. What you should also notice, though, is how low the potency of CBD is, and that's part of what has led to the proliferation of CBD products. So when you go to the CDC, these are the kinds of facts that they have on their website. It's the most commonly used federally illegal drug. And they point out that about 18% of Americans use it at least once. And these are self-reports. The number of people who have cannabis use disorder is still less than people who have alcohol disorders. I think 30% overstates the level of diagnosis. But the key piece of information here is that the risk is highest if you start cannabis before the age of 18. Right now, in just about every state that allows legal access to cannabis, whether it be medical or recreational, the age is set at 21. If we actually followed the research, it would be higher. It would probably be 25, but I think a compromise was made given the legal age for alcohol and various nicotine, for example, in some states has moved up to 21. So the idea is 21 is the baseline age for allowing anyone to have legal access. The issue for adolescents is the developing brain, and you probably heard about this issue, and that's why I mentioned 25. Research has shown that their memory, learning, attention, decision-making, emotion, reaction time, a wide range of effects on the brain of young people who use cannabis. And these areas, such as learning and memory, obviously are going to have impacts on academics and whether someone can be successful in high school or college. And so it's really, really important that we help young people to continue in a positive trajectory rather than disrupt their lives by starting to use cannabis early. The other thing to mention is cannabis during pregnancy is not a great idea. In fact, it's a horrible idea. There are some marketers and others who tried to promote the idea that because cannabis can help with nausea and it's natural, women can use it during pregnancy. The consistent finding is that the birth weight of babies that have been exposed to cannabis is lower than the birth weight of babies that have not been exposed to cannabis. So when we legalize adult use cannabis, one of the things we find is that it promotes recreational use, which seems obvious, but even in states that allow both, recreational use is higher. Interestingly, whether you're using cannabis for recreational or medicinal purposes, different products are chosen. For example, edibles and tinctures and those kinds of products often appeal for medical use. One of the things that we know is that where you see the most increase in the consumption in recreational states is among people who are already heavy or frequent users. So, recreational cannabis does not precipitate huge amounts of increased consumption or heavy consumption, but it's likely to lead folks to think, oh, I could try it, especially because advocates highlight the medicinal benefits. There was the notion that youth cannabis rates would go up. We're not seeing huge increases so far, but again, as the policies evolve, that's something we're keeping an eye on. There is diversification of consumption methods and products. And one of the concerns that I know we heard on the work group for the governor's attempt to kind of learn what New Yorkers were concerned about with cannabis was the impact on traffic fatalities, police departments, sheriff departments. The thing to know, yes, cannabis can, if somebody is really high, affect motor coordination, attention, and some of the other areas that were mentioned. Often what we see in traffic fatalities that involve cannabis is that they also involve other drugs, particularly alcohol. So separating those two can get tricky. Okay, so medical cannabis, we already know, started in California. Subsequently, we've had different policies either based on statewide ballots, similar to California, or state legislatures, as occurred in New York, will pass a medical cannabis statute. Most states and DC have some kind of a medical program. If you remember the map, there were only 3 states that had no access. There are various laws that allow various components. Some focus only on CBD products and some focus on THC and CBD products. And the laws vary as to the symptoms for which cannabis can be prescribed. Which brings us to New York. New York has passed on March 30th of 2021, the Marijuana Regulation and Taxation Act, or MRTA. And the goal for New York and many other states is to have a well-regulated industry. Once recreational cannabis started, there definitely was demand across the country to have access. And the concern was that with an illegal market, people do not know what they're getting. And I share that concern. The illegal market is completely unregulated. And so somebody could give you cannabis laced with fentanyl, which does happen. And other issues around the safety of the product. Does it contain mold? Does it contain pesticides that were used in growing it? And will that affect your lungs and your health? So it's very important to regulate cannabis. The MRTA Act creates 2 regulatory bodies, the Office of Cannabis Management, or the OCM, and the Cannabis Control Board. The latter is appointed by the governor, the assembly, the state. There's a lot of kind of political oversight of these bodies. Recreational cannabis likely will become available in 2023. I know that when the law was passed in 2021, people were like, oh, wait, where are the recreational cannabis outlets? It takes a while to implement these laws. They're very complicated. The product is very complicated. The licensing has to be well vetted. And so it's possible in late 2022, but I'm thinking spring of 2023, so a year from now. There are tax provisions in MRTA. It's a 9% sales tax for the state. Then there's another 4% tax that's split with the county, cities, towns, villages. And then there are additional taxes based on the THC content. So the higher the potency of the product, there might be additional taxes. Localities can opt out of retail sales at the city, town, and village level, which then is going to create a patchwork within New York State that is probably as complicated as the patchwork among the 50 states in the US. So its implementation is going to take a while. So the Office of Cannabis Management interprets the laws and comes up with plans for implementing the laws. The office also regulates homegrown cannabis, which is allowed in MRTA. Each individual can have 3 mature plants, 3 immature plants, total of 12 plants per household, and it also evaluates license applicants. Right now, there's a push to get cultivation licenses going because the plants have to be in the ground pretty soon in order to have a decent growing season. So that's already being implemented. There is a cannabis advisory board that will make policy recommendations and approves grants for what's called a community reinvestment funds. And there is a particular provisions around DUI. There's funding for training of drug recognition officers and the development of technologies for roadside testing. I'm hoping that the technologies will become available. Drug recognition officers are not a way to really assess a DUI. It's not held up in court, and the training that's provided, and people are making a lot of money doing this, is not adequate. It's not enough to train somebody to, look at whether eyes are bloodshot, or even to make a case based on smell. Cannabis, as I mentioned, is complicated. It's fat soluble. THC is fat soluble, and so it can be in your system for hours, even days after you use it. And so the effects could be longer term than we know right now. So these are aspects of the original cannabis program. It was housed in the Department of Health. People got a 30-day supply. Patients could be 18. And there were licensing and limits on who could prescribe, as well as various conditions, Parkinson's, spinal cord injury pain, opioid use disorder. That was then. This is now. Instead of a 30-day supply, people can get a 60-day supply. There used to be a registration fee of $50, and in the community listening sessions, people complained mightily about that. And so that's been waived permanently. You do not have to get you do not have to pay a registration fee, although you still need to register. And the reason why some people might want to register is that medical cannabis is not taxed. And so if you're using it for medical purposes, then registration is a part of kind of what you have to do. Now medical dispensaries can sell just about every type of product. And the list of prescribers has been broadened to include dentists, podiatrists, midwives. A note about prescription. What the prescriber does is essentially say that cannabis can help your condition. They do not specify the form, the potency, and so people go to a dispensary, and it's the dispensary staff that kind of work with them to come up with the product. And there's a big problem there because some of the dispensary staff really are not trained to provide this kind of guidance. Yes, there are pharmacists required. I think it's 1 pharmacist per dispensary, but even the pharmacists are not well trained. I co-teach a cannabis course at UB, and the pharmacy students flock to the course because they're being asked questions and there's no training in UB's pharmacy school, or I would say 98% of the pharmacy schools in this country. Another thing that's changed is that you can now have caregiver facilities like hospitals and schools that can dispense cannabis products. And especially when you're talking about, you know, kids who might need cannabis for epilepsy, I think that's a really good thing. When you grow plants, they have to be secured and not visible from the street, and no selling or bartering or processing of what's grown. There are tax revenues. There is a New York State Cannabis Revenue Fund. Administrative costs come out of that, but the legislation basically stipulates 40% goes to education, 40% to community grants for reinvestment, and a lot of those grants are focused on communities that were adversely impacted by the war on drugs. We've got a lot of people in New York who were sent to jail for possession, and now that's being addressed. And then there is drug treatment and public education. The notion is that beginning in 2023, when the products become more readily available, that New York could raise up to $1.25 billion in revenue from taxes to cannabis. It seems like a big number, but many states are reaping tax benefits. So we'll see what happens in New York. There's a mandate for prevention. We need to look at monitoring what's going on, not just with sales, but how are people using it? How frequently are they using? Are youth using? And in the legislation, it says that there needs to be an annual report. That again is starting to be implemented, but we should have started monitoring what's going on with cannabis in 2018 when this notion came to be, because then we could see trend lines. If we started in 2023, we're kind of just left with implementation and monitoring occurring at the same time, which is not great science. There's public health and education that's coordinated among Department of Health, the State Office of Addiction Services and Supports, and the Office of Mental Health. We're also working with Connecticut and New Jersey to coordinate, even though people cannot legally take cannabis products from one state to a next. The notion was that we don't even want people driving to another state, using there, and then driving back. So I know New Jersey is ahead of us, but there was this notion that we could coordinate public health and education. So we want evidence-based prevention. We want to regulate cannabis products, restrict advertising and promotion, safeguard pregnant and breastfeeding women, and provide general education to the public. And this is an example of general education. You might have seen this on TV. New York has begun what they're calling Cannabis Conversations. This is a 30-second video that I hope works.
New York State has legalized cannabis, and to help understand what that means, we are starting the cannabis conversation. Who can use, where to use, and how to safely use. You must be at least 21 to legally use, possess, or buy cannabis in New York. If you choose to smoke cannabis, do it away from other people. Cannabis should always be stored out of reach of children, and you should never drive under the influence. Join the cannabis conversation at cannabis.ny.gov.
Whoops. So those have started to pop up, and it's a reasonable start, and you can find online a number of videos as part of this cannabis conversation. We need to be more specific. It's kind of very general, but it's a start. I've talked about health and safety. We want to regulate potency, serving size, packaging and labeling, including warning labels, recommendations for serving sizes. Right now, the labels that you see in other states can be all over the place, and I think it's very confusing for people. Child-resistant packaging is essential. And this is a huge issue because there are cannabis products, including edible gummies, that are attractive to children and youth. And so we really have to be on top of that, because there are marketers who sell cannabis products that are a play on the names of cereals and so forth. Again, you know, I don't have a slide with me, but you'd be shocked. And then we have to do laboratory testing of cannabis products to look at purity and to look at dosage. Advertising and marketing, very important. I highlighted, we have to be very careful about products that make medical claims or produce or promote cannabis for wellness. We have very little information that is scientifically valid to tell us about what cannabis can do for the range of disorders that exist. Retail establishments, again, lots of rules. We did have this opt-in, opt-out deadline in December of 2021. And just for points of comparison, when the opt-in, opt-out provision in California, 70% of cities banned. In New York, in New Jersey, it's 70% as well. In New York, more than 400 localities have opted out of dispensaries and consumption lounges. Just some data specific to New York. So this is from the Rockefeller Institute of Government. Dispensaries, 50% opt out, and consumption lounges, which are places where people can gather to use cannabis, 58% or so have opted out. And we have kind of odd things going on. For example, in New York State, we have towns that have opted in, but villages within that town that have opted out. I think Hamburg is in that situation. There's social justice provisions. These communities that have been negatively impacted will get additional revenue for reinvestment. And the notion is 50% of licenses will go to these communities, as well as expungement of records for non-violent drug-related convictions. And that's already begun. So those are positive developments. Even though I've kind of gone through lots of regulations, there's still areas where, as a country and as a state, we need to be very careful, one of which is potency. There is the notion that taxes should be imposed based on potency. And I think some of that could happen in New York. Public health messages that are more specific would be useful. We've got age restrictions, but we also need to restrict hours of sale, outlet density, marketing, and we need to promote or offer less harmful modes of use, as well as interventions for those who want to quit or lessen their cannabis use. In Canada, they have a slogan that says, start low, as in low potency, go slow, as in low frequency. Something like that, I think, can be very useful. So, in conclusion, The cannabis landscape is in flux. It's right now, I'd say, a bit of a disaster, because across the country and within states that allow access to cannabis, the rules are varied so that I think the public often is confused. I think federal policies would help a lot. The House just passed a bill to decriminalize cannabis. That's a start. We've got senators that include Senator Schumer, who are advocating for federal laws that would allow for recreational cannabis and get rid of the Schedule I designation. All of that would be to the good. One of the things that we need is more research. We are woefully behind in building evidence about health effects, prevention, treatment. We're not even sure about what public health messages will resonate with whom. And the Schedule I designation is a huge barrier to research. For me to do a cannabis study where I administer the drug to look at effects, I have to get DEA license, FDA license, and permission from the National Institute on Drug Abuse to get their cannabis. I cannot buy retail cannabis and administer it in research. It's really tough. So on that note, I will open it up for questions. Thank you very much for your time and attention.
Fantastic. Dr. Collins, thank you so much for spending time with us and sharing your knowledge and expertise. This has been such a fantastic presentation with so much information and details. So extremely grateful there. We do have some questions that are coming through. Real quickly, you just mentioned we need more research, we fall behind. Who leads these efforts? Are there countries and states that lead these efforts better than we do?
That's a good question. There are research efforts in many countries. I mentioned Canada. Their cannabis laws are federal. There are variations across the province, but the way they rolled out their cannabis regulations was via a federal law. And that has definitely allowed for researchers to get involved. And they never had, you know, the designation and DEA and those kinds of limits. And so I think it is easier. I know medical cannabis research is being done in Israel. Australia has a lot of research going. I think the complexity of the substance, of the uses that are allowed, it just is a very complicated area.
Absolutely. Dr. Collins, this next question here, will pharmacies be able to sell cannabis?
No. The way that New York and just about every state allows access to cannabis is by designating non-pharmacy outlets. So New York has had dispensaries for their medical cannabis program for a few years now, and then with the retail outlets for recreational cannabis, that will be all that they sell. And then these lounges also, for example, you can gather to use cannabis, but you cannot combine cannabis with alcohol. So pharmacies are not a part of the promotion of medical cannabis. That has not occurred in any state, even in California, which has been doing this since 1996. You have separate entities that provide access.
Excellent. Thank you, Dr. Collins. The next question here, submitted. Can you explain the definition of CUD?
Oh, I'm sorry. Cannabis use disorder. I apologize for using that acronym without explaining it. So the Diagnostic and Statistical Manual that's put out by the American Psychiatric Association has definitions for a range of addictive disorders, one of which is for cannabis. And there's some key questions that allow one to make a diagnosis, including high frequency, ignoring day-to-day responsibilities in order to pursue cannabis use, using cannabis even when it disrupts relationships with others and so forth. So yes, cannabis use disorder is a medical diagnosis.
All right. This next question here, Dr. Collins, if someone wanted to take official steps to become a distributor, where do they go to find the requirements?
You'd probably go to the website that New York State has set up. There you will find all the regulations and requirements. As I said, medical dispensaries already exist. The number of those might grow. Retail outlets, they're working right now on the specifics of who can get the licenses and what all is involved in being a licensed either lounge or retail outlet. I think there are going to be lots of regulations because there is so much concern. And at least for the medical dispensaries, the upfront costs were pretty significant. By the time you got your lawyers and you assured New York State that your facility was secure, that people weren't going to be breaking in to get cannabis products and so forth and so on, it was probably around $250,000, if not more, to go through that process. I'm not sure of what will happen for the retail outlets. I do know that, as I mentioned, the licenses for growing cannabis are just being issued, but it takes a while. There's a lot of vetting and there are a lot of requirements.
All right. And Dr. Collins, we'll do one more question here as we're getting to the top of the hour. So our final question for today, is there a way to get involved with UB for research and education? This person just happens to be a patient and advocate and would like to know more.
Probably the easiest thing to do would be just to contact me. My email is lcollins@buffalo.edu. I can't think of a specific program of research right now that's looking for cannabis patients, but things do evolve. And so if you contact me and let me know what you're using cannabis for and some other details, I might be able to move forward with recommendations. Other things to know, I know Roswell is getting involved in cannabis use related to cancer pain and nausea. So that's something that I know I collaborate with folks at Roswell, and so that's something that's happening. And then the center that was mentioned, a lot of that is academic research. I'm thinking about the medical school and I don't have a particular person in mind, but yeah, just contact me, lcollins@buffalo.edu.
Excellent. Thank you so much, Dr. Collins. And just on behalf of the entire Office of Alumni Engagement, the UB School of Public Health and Health Professions, and really the UB community as a whole, thank you for taking the time again to share your expertise with us. We have recorded the webinar. We'll share it with you within 24 hours. So check your email box for those that might be interested in going back and just watching it again to get some more details, information at your leisure. Our webinar Wednesday series will continue next week, so we'll be sure to share out additional information regarding future topics. So be sure to check your email, like I mentioned, or our webinar webpage for that information. Before I do close things out, I'd like to turn it back to Dr. Collins for any closing remarks on her side.
Well, I hope one of the things you got out of listening to this webinar is a sense of how complicated a substance we are trying to regulate. You know, alcohol, how do people use it? Mainly you drink it. It's oral. Tobacco, how do you use it? Typically you smoke it. Okay, there are some people who chew it. With cannabis, it's all of the above plus. And then, you know, the issues around potency, the issues around medical conditions, the complicated psychological disorders that people sometimes use cannabis for, which may not be in the end in their best interest. It's just a very complicated field. And what I say in my course is to remember, when you talk about cannabis or marijuana, it's not the same thing for each person, each situation. So whatever else you learn, just come away from this saying, wow, that's a complicated drug. Thank you.
Absolutely, definitely. Dr. Collins, thank you. Thank you all for joining us today. Take care, stay well, and enjoy the rest of your week. Bye-bye.
Bye-bye.